Welcome to today's deep dive. We are looking at a stack of sources today that challenge, well, one of the most iconic objects in medicine.
Yeah, the blue asthma inhaler.
Exactly. We've got clinical notes from Dr. Salem, the Beat Asthma Guidelines, and the latest from Asthma Plus Lung UK. And our mission today is to figure out why the consensus is shifting so dramatically away from that classic blue puffer.
Right, because for a lot of people, relying only on that inhaler isn't just outdated, it's actually quite dangerous.
Which is wild to think about. I mean, for decades, the advice for mild asthma was just carry the blue puffer, use it when you wheeze, and go about your day.
It was. But that approach ignores a fundamental truth of asthma. You're treating the symptom, sure, but you are totally ignoring the disease.
Because the blue inhaler, the salbutamol, it's a SABA, right? A short-acting beta agonist.
Exactly, it's a bronchodilator. So it works by relaxing the tight muscles around the airways.
But stopping that squeeze doesn't actually stop the swelling.
No, it doesn't. And Dr. Salem uses this really powerful analogy in his notes. He says relying only on a SABA is like pulling the batteries out of a smoke alarm while a fire is still burning in your house.
Wow, that is...
Yeah. The noise stops, you stop wheezing and you feel immediate relief. But the fire, which is the underlying inflammation, just keeps burning in the background.
So you just get this false sense of security.
Yeah.
I mean, the Beat Asthma Guidelines mention exactly that.
Yeah.
We've basically been training patients to trust a device that hides the...
Hides the danger, yeah.
Yeah.
That is the paradox here. If you can't feel the tightness, you think you're fine. But meanwhile, your risk of a severe attack is actually climbing.
Which brings us to the pivot. The guidelines are now moving toward air therapy. That's AIR, anti-inflammatory reliever.
Right. And you take it purely as needed, no daily maintenance dose. But when you do have symptoms, you use a combination inhaler. It contains both an inhaled corticosteroid and a drug called formoterol.
Now wait, this sounds a little bit like MART therapy, which we see in severe asthma.
They are siblings, but definitely different. MART includes a scheduled daily dose, like morning and night. AIR is strictly as needed. You only take it when symptoms strike.
Okay, and I want to drill down on the specific drug choice because the sources are super specific about this. It has to be formoterol. Why can't we just mix a steroid with any long-acting opener?
Speed is the deciding factor. Most long-acting bronchodilators take way too long to kick in. If you are struggling to breathe, you obviously can't wait 20 minutes.
Right, you need relief now.
Formoterol is unique because it opens the airways in 1 to 3 minutes. That is essentially as fast as the old blue inhaler.
But with the added benefit of a microdose of steroid at the exact same time.
Precisely. You are treating and relieving simultaneously, so every time you reach for relief, you're also putting out a bit of that fire.
Okay, so that sounds great for everyday mild symptoms, but what about emergencies? The old advice for a full-blown attack was to just take rapid puffs of the blue inhaler. Does AIR hold up if you're really in trouble?
It actually has quite an aggressive protocol. The guidelines allow you to stack doses, so if symptoms hit, you take 1 puff. If you're not better in a few minutes, you take another.
And in a severe attack.
You take 1 puff every minute, up to 6 puffs.
Wow, 6 puffs.
Yeah, and think about the biology there. You aren't just forcing the airway open, you're actively flooding the lungs with anti-inflammatory medication right when the inflammation is peaking.
That is so much more proactive, though I assume if those 6 puffs don't work, the advice is still to call 999.
Absolutely. The safety net is always there. Call emergency services. But the data shows patients using AIR therapy have fewer severe exacerbations, fewer hospital admissions, and a lower overall oral steroid burden.
Now, who is this actually for? Because Dr. Salen's notes mention a magic number for age.
Yes, this is for adults and children 12 and over. Pediatric asthma, especially in kids under 5, is a completely different beast. They're managed differently. Kids 6 to 11 also have different protocols.
So this is specifically 12 and up, and mostly for the mild category.
Right. People who only have symptoms maybe less than 3 times a week or aren't waking up at night, or people with specific triggers like pollen, pets, or exercise.
Basically the folks who historically would have just been handed a blue inhaler and told to carry it around.
Exactly. And the beauty of AIR is that you need specific combination inhalers like Symbicort, Duoresp, or Foster, though Foster is 18 plus. But it really simplifies things into a single device.
Yeah, you don't have to remember which inhaler does what.
It aligns what the patient wants right now, which is to breathe, with what the doctor wants long-term, which is to prevent inflammation.
It's a really smart alignment. So if you're listening to this and you or someone you know is still relying purely on that blue whistle, it might be time to ask if you're just turning off the alarm while the fire is still burning.
It really is all about moving from just symptom management to actual disease control.
Definitely. But before we wrap up, it does make you wonder. If the medical community relied on the blue inhaler for so many decades before realizing it was masking the root cause, what other routine, everyday treatments in our medicine cabinets are doing the exact same thing? Just something to mull over on your own. Thanks for joining this deep dive.
Thanks for exploring this with me.